Facebook page or something?
Sorry, we didn't prepare for it.
Okay, okay. Mhm.
Uh,
All right. We have reached 50 participants.
Great. That's wonderful. That's very good participation.
Good. So let us begin. Yeah. So very good evening from Pune, and good morning and good afternoon, depending on where you are. This gives us great pleasure to present our first webinar from the special interest group on culture and sexuality, special group of the World Association of Cultural Psychiatry. And the topic of interest today is culture and the prevention of sexual violence. So we expect that it will be useful for everybody, and we expect that it will go on increasing in its scope as we keep on working in near future. So I welcome you all, especially thanks to Pablo, our secretary, Mario, our president and guardian angel, the Dutch Psychiatric Association, and our home team. Dr. Laila Garda is our director, Varsha Tol is senior research consultant, Ghanasham is managing the computer and the webinar, and we have Dr. Ujjwal Nene, who is a clinical psychologist and a sexual health consultant with 30 years of experience of running a pioneer clinic in sexual health at the KEM Hospital, King Edward Memorial Hospital. That's the colonial legacy that we have, the name of the hospital. And then she will explain to us about the Indian experience of various functionings and problems related to sexuality in Indian culture. Followed by that, we will have Ankita Deshmukh. Ankita will speak to us about the role of socio-cultural case formulation in prevention of sexual violence. She has been a clinical psychologist working with us on cultural formulation since time immemorial. And here we have Dr. Suchita Agrawal, who will follow her. She will speak about our Indian experience on primary prevention of sexual violence. So I feel particularly good because our team comprises of 3 ladies, important ladies in psychiatry today, and I'm just holding the chair. So we can speak about gender equity with a free hand. So I don't intend to take much of your time, and allow me to share my screen and hand over the presentation to Ujjwal for her presentation. Let me just see how I can manage that. Can you see my screen?
Yes.
Great. Let me reduce this view so that only the speaker will be shown. Yes, Ghanasham, is that okay?
it is, I guess, the presentation mode is yet not been started.
Yeah, I have started that now. Let me stop the projected screen, I suppose. Allow me a moment. Yes.
Okay.
Yeah. So now you can see I'm handing over the presentation to Ujjwal, our first speaker. Another point that I noted was that all three of these ladies, they are so experienced and competent that each of them is capable of taking one full day of workshop on their topic. So I have little work to do in the beginning until we reach the question and answer and discussion section. The important thing I wanted to highlight was when we began this program of primary prevention of sexual violence against children by offering treatment to persons with pedophilia who were non-offending and self-motivated, self-identified people, the question came, what is the role of culture? And it became a point of interest that it is actually the society and culture which define whether a particular sexual act is legitimate, like in a honeymoon, or is it an affair when only the two persons are agreeing, other people either do not know or do not approve of it. And the third category, sexual violence, is where only one person is agreeing and the other is not, or the consent is obtained by fraud. Thus, it is the society and the cultural norms and structural context that determine how you address that particular sexual act. Therefore, culture and society, like pointed out by Parker also, it is more and more important to consider the attachment function, not just the biological and psychological functions of reproduction and pleasure. So sexuality is at the center stage of human life, not like it was taught earlier that it is just another dimension of human personality, but it is at the center stage, and socio-cultural matrix is as important as what is happening in the sexuality regarding the life or the problems. With this, I hand over to Dr. Ujjwal Nene. Ujjwal, please.
Yeah, thank you, Vasudeo. And thank you, WACP, for allowing me to share my experiences and having me here to share my experiences. Yeah, next. This will be my overview. This is overview of my presentation. Generally, I'll be talking about Indian settings, culture and sexuality, sexual health clinic, clinical sexuality, influences on sexuality, current scenario, dealing with sexual issues, and prevention of violence. Yeah, India is the largest democratic country with second largest population in this world. And there are some 28 states, and I am from Maharashtra, and I will be sharing my experiences from Maharashtra. Next. Next. Vasudeo, next. Yeah. So India has its rich cultural heritage with, go back, with cultural heritage with diversity. Our culture is some 5,000 years old, and there are multiple traditions and multiple customs. Those are rooted over the generations. There are 30 official languages, and believe me, there are literally hundreds of different languages are spoken in India. Most importantly, we see variety of sexual expressions in our clinical settings. For example, a man who is coming from Punjab state, who is with open culture, will express his sexual behavior or sexual expressions, or maybe its difficulty, in completely different manner if as compared to a person who is coming to me from state of Karnataka with very conservative culture. So we need to understand the cultural background before we start, evaluating their sexual problems. Next. When it comes to sexuality, our culture is of silence. Talking openly about sex and sexuality is considered as indecent and uncivilized. In general, sexuality is a taboo topic, and talking about sex and sexuality in family settings is not permitted and not accepted due to stigma attached to it. Hence, there are many myths and misconceptions related to sexual functions and sexuality and all. Vasudeo, go back. Yeah. So hence there are myths and misconceptions, and we have to deal with that also. For example, the size of penis, or maybe thickness of semen, or maybe duration of coitus are having multiple expectations from people, males and females. Sometimes physical attributes like skin color, facial features, or maybe hair, size of boobs, all these factors are considered as sexually attractive. And similarly, men also have some expectations from their body. And that is why detailed understanding about their thinking, how do they think, is more important in clinical settings. So now, next. Now, so how do I started working in sexual health? There is a story behind that. In 1996, we started working on the project by KM Hospital Research Center, improving women's reproductive health through men's involvement. And male clinic was a service part of this project. So that time, what used to happen, menstruation, pregnancy, delivery, abortion, etc., was a female domain, and there was no role for a man to play in. So from this project, we were expecting that we can encourage men to have interest and involvement in their reproductive health of their wives and female in general. So Dr. Banu Koyaji, who was medical director of our institute, and she was Padma Vibhushan and Magsaysay Award winner and great visionary. She said, we are expecting their involvement, but let us see how far they are interested in their sexual health, and do they come ahead for seeking treatment for sexual dysfunction or sexual problems. So this is how we started working on this, working in this clinic. And I'm working since the day of conception of this clinic. And also that was a time where prevalence of HIV and AIDS was very high, and there was need to create awareness about RTI, STD, safe sexual practices to prevent HIV and AIDS and all. Next. So what kind of issues I am dealing with in this clinic since last more than 2 decades? That syndrome, as all of us, we know that that syndrome is a case where a person feels tremendously anxious for losing semen via masturbation or via nocturnal emission. This is a issue where person will have multiple symptoms like body ache, low memory, or maybe no concentration, no confidence, backache, ache in thighs, and etc. and etc. And then this is that syndrome. But nowadays, actually, I'm not having such cases, really speaking. Then male and female sexual dysfunction is a large amount of patients are coming with this. Especially male dysfunction is strongly associated with shame and guilt, and it is perceived as a threat for his male identity. And that becomes very problematic for a person to come forward and to seek treatment. Again, infertility and related issues. Infertility is highly stigmatized condition and highly stressful for a couple. So in case of infertility, I need to deal with their sexual issues. If they are having sexual dysfunctions, I have to deal with that. Then I have to deal with their emotional regulation. I have to teach them emotional regulation and how to manage stress and how to have communication with their family members, because there is a lot of pressure from both the families, from girl's family and from the man's family also. Then pre-marriage counseling is actually becoming now more important in clinical settings. Good that people are aware about sexual issues, and before marriage only they come for some clarifications. Then very small number of patients are also attending this clinic with sexual disturbances, gender dysphoria, paraphilias. And in such cases, my job is to give them psychotherapy. And this, actually, these individuals are not accepted in general by community and by family also. So I have to talk with their families and to create acceptance for these individuals, firstly in primarily in family settings, and then in societal this thing, and to build their confidence, to give them proper guidance about their lifestyles and all. So these are the individuals who are now they have started coming to clinic. Then sexual issues of challenged individual, for example, intellectual deficits or physical handicap or children with autism, they also sometimes come with sexual problems to sort it out by clinical help. Then CSA victims and their families and children with in conflict with law, sometimes those children are also referred for counseling and psychotherapy. Basically, I would like to make a point here that all these sexual problems are equated with feelings like shame, guilt, anger, anxiety, conflict, fear, and so forth. So feelings of helplessness, feelings of inadequacy, frustration are very commonly seen when I'm dealing with these people who are coming to this clinic with sexual problems. Next.
Madam, here let me request you to wait for about a minute, because it is being seen in the presenter view. So let us see if we can sort that out.
Okay.
Just a moment.
Sir, we can do that. Just go to display setting.
Display settings.
Above, there is option above. Display setting near the show taskbar.
Show taskbar.
Display setting. It is there. It is there. Right side. Right side. Right side. Right side to the show taskbar.
No, the right side to the show taskbar is mute.
You can see.
Display setting. It is there. It is there only.
I can see that actually.
Huh?
Middle of this
Huh?
show taskbar and
End slide.
end slideshow. In between there is one caption.
For now.
Yeah.
Is this better?
We
Yeah,
have to
now
share
this is,
now.
I think this is
We
better.
have to share now, no?
No, it's done. We're sharing.
Okay.
We can't.
Hmm?
Change the slide.
So I will continue with this slide.
Yes.
So when I'm dealing with
Sorry about
sexual
that.
problems of people, I have to take care of their emotional management also, because in Indian settings, actually having sexual issues or sexual dysfunction is stigmatized a lot. So managing all this is challenging, but still it's very gratifying for me. Next. Next, Vasudeo. Okay, so these are some of the quotes from my cases. First is the one that the first case is a husband who was actually gay, and he was trying to reduce his guilt by such a justification that he's giving everything to his wife and then she should not complain. But his wife was deprived of sexual pleasure, and even romantic proximity was not possible for her with her husband. So it was a case of female was deprived because husband didn't disclose his orientation disturbance, and he got married because of family pressure. His family was not aware that he was a gay person. Then the second is a case that this lady, she came to me for seeking help, and she said my husband is having very weird kind of demands, and he is asking me to have sex with his friend, and which is impossible for me. And then she said he is now using his mother, and in Indian cultural settings, mother-in-law is having superpower. So poor lady, she didn't understand that why her son is complaining about my wife is not cooperative in bedroom. So she started telling her that you have to cooperate to your husband. You should not say no to him. But she didn't know the fact. Then I started calling her. I tried to call her husband in clinic, but somehow he didn't come. Then I had to expand my boundaries, and I called her mother-in-law. I explained everything to her, and then possibly she must have discussed this with her son, and finally the topic was closed. I don't know what was this case of her husband. Perhaps it was an influence of watching pornography, or maybe some excitement or feeling while his wife was having sex with somebody else, or it can be some psychiatric comorbidity. I don't know don't know the reason of the behind this, his behavior. Then the third example is verbal, ridicule and verbal abuse of husband by wife. And this man was unable to perform sexually. And just she used to say in publicly that, oh, my husband is not able to spread bedsheet. So in bracket, what else I can expect from him? He was not performing, and this has become one maintaining factor for his erectile dysfunction. The last case is again about infertility. The 3 years this marriage was without having kid, and the female was under tremendous tension after, and she was having vaginismus, and then I had to work with her for 3 to 4 months to overcome the fear and the vaginismus and all. And after completing the treatment, I said, no, okay, now you can go ahead and have sex and all. And her husband, somehow he came and he said, oh ma'am, even I am having problem of suspension of erection, and I come out very fast during masturbation, so now help me out. But you can understand here that the female was, having tremendous tension of infertility, and she was having guilt because she was not able to give child to the family. And her husband took a role of a spectator. So sometimes you feel so bad about when you see such kind of, injustice on one person in couple sex therapy. Next. Next. Yes. So if we consider about what are the socio-cultural influences on sexuality and sexual behavior, of course, religion comes first because there are multiple do's and don'ts. Basically, societal and cultural norms, they are also very influential, directly or indirectly influencing people's sexual functioning. There are set societal norms like what is accepted and what is not accepted in given situations. Then family and parental influence is also very important, and it plays a significant role in sexual practices of males and females. Then sexual behavior again is highly influenced by gender roles and deep-rooted beliefs about masculinity and femininity. There are prescribed gender roles and sex roles for both the genders. Like, for example, I can say female should not take dominating role or initiative in sexual activity, whereas the man is supposed to show his dominance in sexual activity. So this is how the things are happening in bedrooms, and we have to, understand what is exactly happening there. Again, there was no formal education. There is no formal education, sex education, or understanding of healthy sexuality. So these are the factors which are actually influencing sexuality and sexual behavior of people. Again, media, politics, literature, there are multiple factors which are influential for human sexuality in Indian cultural settings. Next. Now I will like to give you the present scenario. So these are some positive changes as far as my clinical experience tells me, that now that syndrome is almost disappeared kind of a thing, because I think people are getting knowledge about semen and about sexual functioning and everything. So then ED, for example, erectile dysfunction or male sexual function dysfunction, more acceptance from both the genders, both the partners, and openness is there for treatment. They will continue to come for therapy, sex therapy, and they will get adjusted with their office routine and everything. And they actually complete the therapy of 4 months or maybe 6 months sometimes. Then there is increased gender sensitivity and flexible gender roles, which is again a good part. And it is not stringent like it was like 2 decades back. Very stringent roles of males and females I used to see in clinic. Then infertility, not only the female is exposed to treatment, but even males are coming forward, because there is a understanding that even male factor can have some positive factors for infertility. So this is again a good sign. Then live-in relationship in our culture is taking roots, and sometimes even these young couples are coming who are in live-in relationship with their sexual issues. Then watching pornography was considered as a very shameful act some 2 decades back, but now it has become a common activity of people, and there is no guilt or no shame, but sometimes it takes shape of addiction. Then one needs to be little careful. Then more safe sexual practices are prevalent in Indian settings, and to prevent HIV and AIDS, and people are now aware about all this. One has to use condom if he's going for sex with, or to have sex with sex worker and all. Then nowadays schools are more open for sex education. I remember in 1996, 98, we used to go to different schools for increasing awareness about family life education, we used to call. But school used to say, no, we can't take a role of a teacher in this, and our schools will not be, we are not very comfortable with the idea to share this sex education in our school. Then there is increased awareness in the society in general about LGBTQ, and there are self-help groups for this. And then a repeal of IPC 377, that is homosexuality was considered as a criminal act, but now no more the act is active in India. Unfortunately, there is an increase of sexual offending in general, and also child sexual abuse. But I think there is less understanding about POCSO, the law, and I think Ankita is going to talk about that later. Next. So in my point of view, cultural clinical sexuality is like a big jigsaw puzzle, and you really have to understand multiple factors, cultural background, and factors like his education background, his family constellation, then his religious practices, and so forth, and need to evaluate the sexual problem in totality, considering all factors in their lifestyles. Then intervention should be planned in culturally suitable manner, because as we understand, we are having diversity in cultural aspects. So we need to understand the cultural background of the person, and the intervention which we are giving, or therapy, or maybe therapeutic conversation for that matter, or examples or metaphors that we are using for when we are dealing with sexual problems. You have to understand the cultural background. Then this sexual issues, this is very difficult for a person to disclose his failure in sexual performance, for him or for her maybe. So these issues are very delicate, and one has to deal with delicacy and careful approach. Then many times what happens, emphasis is given on only body parts, body and physicality, and how much time, and how hard erection and this and that. But I think somewhere in therapy and in therapeutic conversation, you need to give emphasis on emotional connect, trust and romantic relationship. Even foreplay sometimes is missing, afterplay is missing in many cases. So I think clinicians should be giving emphasis on psychological and emotional component of sexuality. And whenever you encounter any kind of act which is leading to sexual violence, I think we have to stop that at our level and without wasting any time. Next. So this is a responsibility of a clinician to stop violence. And what are the ways? So providing psychoeducation about sexual interactions, about roles, about needs, about human sexual response, that becomes very essential when one is conducting sex therapy. Sex education is also very important. Then working with core beliefs. Sometimes people are having beliefs like, I'm not sexually attractive, I am not lovable, my spouse is not liking me because I'm not having fair color or whatever. So we need to work with core beliefs, and one has to be very attentive when he's trying to understand core beliefs, or maybe he's dealing with cognitive distortions. Sometimes I feel there are cognitive distortions and which are very subtle, and one has to be very attentive during the conversation. Because for sometimes I can give you an example, like the woman who is having big boobs will have strong sexual needs. It's again cognitive distortion. Or for a person who feels that his semen is getting thin and thinner, and I'm losing my power as a man. So this kind of explanations, justifications, or maybe even in sometimes light conversation, they will come up with this ideas. So you need to correct their attitudes, their cognitions. Then treatment for dissexual behavior. Now, what is dissexual behavior? This behavior, the purpose of this behavior is definitely to have sexual pleasure. Okay, so though this behavior,
just a little consideration for time, please.
yeah, this is last slide.
Thanks.
So though this behavior is not considered as illegal, it violates integrity and individuality of others. Consent cannot be expected for this behavior, and as it can result in self-harm or harm to others. So we have to work with this sexual behavior of any partner. Then gender sensitization and women empowerment. Sometimes if a female is coming from rural sector, I need to work for women empowerment also. And introducing and establishing healthy sexuality is primarily very important aspect of prevention of sexual violence. So finally, in nutshell, I can say that understanding the cultural background and cultural frame of patient and being sensitive to the same is an integral part of any effective treatment in clinical sexuality. Culture is hard to separate from the bodies and minds of people, and which is woven through generations, deeply rooted in the psyche and reflected through their practices. Thus, effective treatment necessarily starts after thorough clinical and cultural assessment. Thank you.
Thank you, Ujjwal, for that wonderful delivery and authentic experience. There are some questions in the chat box, which we will take during the question answer session. We have noted them.
Yes.
Let me hand over to Ankita for the next session, please.
Yeah, I'll just start sharing a moment, please.
Yes.
No. I hope it is visible. So, good evening, everybody. This is Ankita. Good evening from India, and I'm sure it's morning somewhere and afternoon somewhere else. Today I'm going to be talking about role of socio-cultural case formulation in preventing sexual violence. So there is a beautiful background that Dr. Ujjwal Nene ma'am has set. So hopefully my work is cut down a little bit. But I will still be focusing on the socio-cultural case formulation. This is the overview of my presentation. I will be talking about sexual violence, just to set a context of what can come up as sexual violence, levels of prevention, then the SCF framework that we will be talking about, what are we likely to encounter in this assessments, and what are the preventive interventions that we can think of on basis of what comes up. So just to set the stage, like what is sexual violence and what can come up. So WHO has a very broad definition of what is sexual act. And I understand that there are 4 features of that. I'm not reading the definition, but to summarize, there has to be a coercion of some kind of force, intimidation, blackmail, manipulation, or a threat, the absence of consent. Then there is force to do something degrading or humiliating. Just an example we saw in the previous presentation of the husband wanting to watch. So it was not acceptable by the wife. Had sexual intercourse when the person didn't want to, because if she was afraid or they were afraid that what will happen if they don't. This is a good point to tell that my experience has majorly been with women, but I've tried to make it as inclusive as I can. So I wouldn't have much clinical experience in understanding the experience of violence from all people, but that's why my examples will be more skewed towards women and children, if at all. The next is levels of prevention. So fortunately, we have a presentation right after this on primary prevention, which is any prevention that takes place before before any act of violence takes place. For example, even delivering sex education or sexuality education to children so that they can identify or understand when things happen, even to their parents, teachers, or children, everybody, is a form of primary prevention. Secondary prevention happens right after an incident has occurred, which can involve first aid treatment or any form of immediate assistance that is required for aim of safety, to ensure that there is no occurrence again and the person is safe. And the tertiary prevention is a long-term impact that we will be that we try to aim to understand the long-term impact, and the aim is generally to rehabilitate, to work with the memories. So we will be more talking about secondary and tertiary prevention in this presentation to understand what can we do after that. So this is the framework for socio-cultural case formulation. So a little bit background of how we came about. We have been in Pune, KM HRC has been involved in the field trial of CFI, which is the Cultural Formulation Interview, DSM-5. And post our study, we understood that there are more aspects that we need to include. So we expanded a little bit more on cultural identity and added societal structure. The study for the same is still going on in the KM HRC Research Center. So there are 4 domains that we try to keep in mind. So this is a framework right now that is like a theoretical background and not the complete assessment that I'm presenting. So the 4 domains we try to understand a person's socio-cultural context is cultural identity, illness explanatory model, key social relations, and societal structural context. So cultural identity briefly put is what aspects of my culture am I internalizing as a person? Like my family may be, for example, joint family, but I am more of an independent person. Or my people around me may prescribe to one religion, but I may or may not. So what are the aspects that I have internalized? Illness explanatory model is about understanding the illness from their perspective. To simply put, it is like a diagnostic formulation. I'm going in detail. I know this is WSEP because there are many Indian people here who may not be familiarized with this concept. So I'm going tad bit detail in understanding the framework. So illness explanatory model is nothing but diagnostic formulation from a person's point of the patient's point of view. What do they understand by their symptoms, the meaning, causes, expected health? In key social relationships, we understand all kinds of relationship, and we have included social, virtual, as well as clinician-patient relationship in this. And the societal structure is the structure or the context where the patient is living in. For example, environmental, socioeconomic, discrimination, opportunities, social media, legal policies, etc. So this is the brief, very, very brief, a scratch background of what socio-cultural framework is. Now, what are we likely to encounter in each of this domain when we see any reference of sexual violence? When we talk about cultural identity, we may see beliefs about sexuality and gender in general. Something like a person may say, as a woman, I'm expected to be virgin before I get married. Or men may say, I am a provider of the house, so I have to always be strong. And a lot of marginalized sexual identities may stay, not have been disclosed to their families. Then varying degrees of tolerance for coercion, especially in marital setting. A lot of women will believe that it's okay, he's just my husband. Or something like, I can't just directly complain against my husband, it's just first act, second act. Then the prescribed or accepted solutions for violence, even now, right now in India, many times at grassroots levels, at interiors, they will be married off to the perpetrator, or they will be expected to sustain the marriage, that it's okay. So these are the beliefs and attitudes that a person may come up with when they explain and experience the instance of violence. In the next slide, though, I have tried to incorporate a range of identity expression that we can see in our culture. There are still virginity tests. Yet we have a president currently appointed from a marginalized section of women. Yet we have advertisements where there is a shared responsibility, symbols of goddesses who slay the demons, Kama Sutra, and now a lot of inclusion of transgenders in syllabus. NCERT is our school board. Illness explanatory model. So people may talk about violence or occurrence of violence while explaining sexual activity, or their own health problems, or even directly talking about abuse. Meaning and cause attributed to instances of violence can be broadly categorized into victim blaming, either the victims themselves blaming themselves, or even narrating that people around them are blaming me. Like, I should have understood better, or I should have been more careful, or in the picture that we see, you were wearing something that was objectionable. Or there can be rationalizing of the perpetrator's intent, that I must have something wrong in me that the person is doing, person felt compelled, like she asked for it, or boys will be boys, so why are you complaining about it? And expected help may not be what it feels like the help. Like, the person still may say, especially in marital context, that, oh no, doctor, I need to make this work, or I need to stay quiet because the perpetrator is in my family. I can't go and disclose this to anybody else. Then key social relationships. As I just mentioned, relationship with the perpetrator is extremely important, because the closer the perpetrator is, the difficult it gets to mitigate and stop violence. Attitude of their family members, like, so what? It happens with everybody. Even in the endurance or tolerance of the coercion, a lot of women in India will experience sometime a touch in public transport, and that touch is generally negated or not mitigated because women around only will say, okay, it happens with everybody, just ignore. So that is another example. Or just endure a little bit. And if help or support any, so there is an example of this group right here, Gulabi Gang, which is pink color gang of women in a village who came together to protest or to act against men who were incurring any form of violence, or it was a women empowerment group. So such supports are also available. And then threats in clinician-patient relationships and expectations. So we expect clinician-patient relationship to be the safest, and if at all, for any reason the person is perceiving threat, we may want to have that kind of help, like a female doctor, or if the person is not feeling okay with the male doctor. Then societal structures, there is a Me Too movement that came up on media. So the structure of media helped us all come together and open up about our sexual violence experiences. So that infrastructure, that structure really helped everybody. At the same time, it could also be discriminatory. Then the norm, stigma, and discrimination experienced by the victim, and the laws related to, I will just have a slide on laws, I'll just come to that. And health facilities, are they safe for the victim, or even are they available for perpetrators, or what are the facilities that a person desires to have? So just to know that there are several laws in the realm of sexuality, like we have a law against selective sexual sex determination. At the same time, abortion is legal. So these two laws do exist, but doctors are doing fantastic work, a lot of them, in having both of these sustained together. Just now we mentioned that the 377 section of that criminalized homosexuality is taken up. This small visual shows the history of how many years it took to come to this place. Then there is POSH Act, which is sexual harassment prevention in the corporate or the company work. Then there is POXO, which is a very stringent and very child-centric act in our country for protection of children against sexual violence. Then there is Trans Act, which was just in 2021, which tries and attempts, I would still say, to preserve rights of trans persons. There is still a long way to go, but we do as clinicians need to be aware of these laws and in our country and mechanisms that are there to protect. Now, knowing that this happened, just to set the stage for preventive intervention, I refer to the river of integration concept by Dan Siegel, that any victim may come in the island of rigidity or island of chaos when we may see them in the clinic. And our aim as clinician is to ultimately slowly integrate them into the flow of life. And this is my representation of doodle of the same concept. I thought of putting it up. So I'll just come. So now what we understand from the SCF framework is, who is the person that was impacted? Okay? Who is this person who came to us? Is their cultural identity rigidly held, or there is more disturbance after this incident, that they're questioning a lot of their own identity values they held up till now? So we help the patient renegotiate and internalize these frameworks that are adaptive and empowering. So there is a very famous Hindi song which says that, next birth, please don't make me a girl. So maybe this is the identity that this person held before or now, but we want to take them to the next song, which was interestingly written and composed for a show which discussed child sexual abuse on television. The song is called Rupaya, which is like, I'm not equated to as a woman equated to cash or money, because there are dowry system here also. So we want to take the narrative from one identity which is very rigid or even chaotic, as I said, could be, to more adaptive and empowering. So that would be only possible when I know who this person is, what are the identities they held close to themselves. Now, what is the person suffering from? So just knowing the instance or the situation is not enough. So here in the illness explanatory model, the person has opportunity to explain their experiences, the meaning that they give to it, and we may understand how withdrawn, distressed, confused, vulnerable the person comes in, and the way they are experiencing shame and despair. We know they may experience, so they will, but we don't know what is making them experience that shame and despair. So this is what illness explanatory model will help us know. So once I know the context in which the person is experiencing this problem and the meaning they're ascribing to it, I will know how to tailor the psychoeducation, and in the secondary prevention phases, prioritize the goals. So though I want to make the person safe, how to make the person safe depends largely on the context of the person. For example, even in POCSO Act, even if they say mandatory reporting, for the clinician or anybody who knows that the person has undergone violence, will I as a clinician first just go and report, or try to prepare the people, because they can get hostile and turn away because perpetrators are from home? Prepare them, make them understand, and then report the problem. Or just right now, supportive psychotherapy or just listening is enough. So that is the value of illness explanatory model. The next is, with whom does the patient feel supported? That is the key social relations. So we are working towards enhancing the social supports, identifying varied sources of support beyond family and immediate caregivers. It helps them have empowerment, and ensuring the safe clinician-patient relationship. Like sometimes even letting the person choose which clinician to work with. If not me, I will make you go to another, or I'll give you different references. Now, where does the client or the patient comes from? That is the context, the rural area. Are they from the most marginalized section, or they come from an area like there are khap panchayats or media reporting, if any, how to make them safe, or social work support, what do their context requires them to do? So in summarizing, this quote I have taken from Dr. Paralikar, to be very honest, but it really summarizes the socio-cultural formulation very well, that if we have to teach English to Johnny, we need to know Johnny. So if we have to deliver any preventive interventions, we need to know who the person is, what is the problem that they have, who they feel supported by, and does this person come from. So therefore it helps us clarifying the meaning of the situation and the experience. So it enhances the rapport, trust, therapeutic alliance, and deliver the expected care. So it's the bridge. The SCF framework is a bridge from the theory that we know and what the person needs and how can we bridge that gap. So overall, that is why it is one of the most important pillar for delivering person-centered care. And that's where I end my presentation. I know I've missed out a lot of points maybe, or I was too fast, but I hope it gives what I wanted to say comes across. So, thank you so much.
Thank you, Ankita. This gives time to Suchita, who is a little delayed, but we hope you can make it up.
Yes, thank you
And
so much.
we hope the Ghanasham also will allow that to us.
I will just
Yeah.
pull that out so that that only windows. पहले share करूँ box. Oh, right. Thank you so much, Ankita. And I will be speaking on Indian program for primary prevention of sexual violence. Is my screen visible? Okay, great. I'm Dr. Suchita Agrawal. I'm a psychiatrist who was associated with the project, and I'm very glad that we have Dr. Vasudeo Paralikar and Dr. Ujjwal Nene, who are both principal investigators on the project, as well as our team, the project coordinator, Varsha Tol Madam, and the director of KEM Hospital Research Institute, that is Dr. Leila Garda. Thank you, everyone. The overview, I will be speaking briefly, just touching upon, because the program is huge, I'll just touch upon some of the topics. The introduction to the program, the epidemiology related to it, terms and conditions, cultural and legal challenges, cultural adaptation, treatment, and then we'll go on to questions and discussions. I would just like to introduce the program firstly. So it was started in 2015 in India. It was an Indo-German collaboration at KM Hospital Research Center, Pune. And the German project has been running since 2005 under Dr. Klaus Bayer. It is called the Prevention Project Dunkelfeld. The aim is to prevent sexual violence against children through treatment of persons with pedophilia. Presently, the toll-free helpline is ongoing, which is a 24/7 helpline where people can call up for help, treatment, and collaborations with various institutes. There is also an online self-management tool which is free to access, completely anonymous, and is on a server which does not take any of the data so that you're not tracked or traced. Here I have a picture of the team, and I'm very glad that we have psychiatrists, psychologists, project coordinator, social workers. So it was a multidisciplinary team to cater to all the different aspects of the project. Let's look at the epidemiology. Pedophilia, the prevalence in general population is not known. There is a wide variety of research, various criteria have been used, and it's very difficult to get an accurate or generalizable data. In general, it is assumed to be about 1 to 5% in males. DSM says 3 to 5%. Females, 0.8 to 2%. Prevalence of child sexual abuse in the offenders is 40 to 50%. So now this is the section of abuse that we are trying to prevent through this program. Rate of offending is again not known. However, the people who approached for treatment in the prevention project Dunkelfeld in Germany, out of them 43% had already offended. And in the juvenile prevention project, 45% of them had already offended. And this includes both contact as well as non-contact offenses. So some of them may have just viewed child sexual abuse material, popularly also called child pornography. Prevalence of child sexual abuse, again, similarly, the data is very diverse. Worldwide, 9.6 to 12.5%. And in India, if you will see, it's even more varied, from males 4 to 41% and females 3 to 39%. What is important to note in the data in India is that we found a slightly higher prevalence in males as compared to females. We don't know why that is. We definitely need more studies. Let's go to some terms and definitions. So paraphilia in DSM-5 is any intense and persistent sexual interest other than sexual interest in genital stimulation, preparatory fondling with phenotypically normal, physically mature and consenting human partners. ICD-11 does not define paraphilia separately, it's just included in paraphilic disorders. Now, what is paraphilic disorder? So we looked at what paraphilia is. When added to that, there is distress, there is some impairment in interpersonal functioning, or it involves others who are unwilling or unable to consent, or it may result in significant risk of injury or harm to others. So that encompasses both the definitions of in ICD-11 as well as DSM-5. Pedophilic disorder. So we are going from paraphilias to pedophilia, which is a specific paraphilia. Again, I've put a comparison of DSM-5 and ICD-11 definitions. What is important to note again here is recurrent, intense, and persistent arousing, sexually arousing fantasies, urges, or behaviors. So they have to be persistent, so, transient, experimental. Sometime it has happened in once in a while, then it is not diagnosed as pedophilic disorder, and it is directed towards prepubescent child or children. Second criteria, most importantly, is that the person should have acted on them, or it must cause distress or interpersonal difficulty, and it is not to be diagnosed among pre or post-pubertal children or those who are 16 years or younger. And the age difference between the two has to be at least 5 years. In DSM-5, there are specifiers: exclusive, non-exclusive, attracted to male, females, or both, and limited to incest. Hebephilia and teleophilia are not defined in either DSM-5 or ICD-11. Hebephilia is considered a sexual attraction to early pubertal body age, and teleophilia to late pubescent or adult body age. Now, what is this I'm talking about? So it is defined by Tanner stages. When we talk about prepubertal, it is Tanner stage 1. So pedophilia is Tanner stage 1. Hebephilia is Tanner stage 2 and 3. Teleophilia is Tanner stage 4 and 5. 4 is also sometimes called late pubescent, and there is another term that is sometimes used called ephebophilia. Primary prevention of sexual violence. So what are we doing in the project exactly? So we are trying to stop abuse before it can occur. That is what primary prevention is. And what are we doing? Who are we targeting? Is those who are at risk of being offending. So there are two targets that can be there in primary prevention: the child and the person with pedophilia. But the project specifically focuses only on the person with pedophilia. So the child does not become a victim, and the person with pedophilia does not become an offender or a criminal. Now, there is a term called as surrogate offenders. Now, if you remember in the epidemiology, we saw that in child sexual abuse, only 40 to 50% abuses caused by pedophilia or people with a pedophilic preference. 60% of officially known offenders have no sexual preference disorder, but for different reasons, they may abuse children. These reasons may range from a wide variety: intellectual disability, adolescents with no experience in sexuality. It can be any person who has antisocial personality disorder, or any wide variety of psychosis or any of the psychiatric disorders. So we are not focusing on that. Reason being, it is very difficult to reach this population, and it is very difficult to identify the risk in this population of who is going to offend. Whereas recidivism rate, that is the rate of reoffending. So again, in pedophilic offenders, it is 30 to 50%. So they're more likely to offend than surrogate offender, where the rate is 10 to 25%. Let's look at some of the cultural and legal challenges that we faced in the project. Cultural challenges. So again, Nene ma'am and Ankita has made my work very easy by already speaking about some of the cultural challenges. There's a lot of stigma about sexuality, huge cultural diversity in India. There is reliance on non-psychiatric help very much. They will try to go to general practitioners, faith healers, all kinds of friends, family, relatives. Everybody will give advice before they come to a mental health practitioners. There are various barriers to help seeking. One of the major ones is, of course, stigma, but cost, distance, lot of fear about mental health, treatment. So all these things are there. Legal challenges I want to focus on specifically because this is something that in dealing with people who have pedophilia. So the act that governs it is the POCSO Act of 2012. And that says that anybody who has offended needs to be mandatorily reported. So the clinician is put under this responsibility that any person, if they approach us and they report that they have either offended a child recently or in the past, anytime after 2012, then it is mandatory to report. So this makes our work pretty difficult. The clinician-patient relationship becomes difficult to establish in this case. We are not, so even if the person has not been, is not a criminal officially, is not been reported to the legal services, we still cannot go ahead with the treatment without putting them across to the legal authorities. Adolescent exploratory play under this act can become a criminal act because both the adolescents who are participating willingly or exploring can become both victims and offenders. Age of consent is another area where as the age of consent is different from the age defined in the POCSO Act. Age determination again becomes difficult in the clinical setting when somebody comes to the clinic to say whether or not they are above the legal age or not. Some of the clauses under the act are unclear. So we had this difficulty where if the person has not done a contact offense but just has viewed online material, child sexual exploitation material, then are we supposed to report them or not? Similarly, for children, if they are already an adult, then do we have to still report? So even if the child comes to us and says that they have been offended in some way, then like Ankita mentioned that we have to report. But when do we report? That is again a question. It's a thing for contention, which can be debated. So the cultural adaptations that we took up were we gave individual therapy versus group therapy that was part of the German program. We invited only non-offending people with pedophilia or hebephilia. In the informed consent, it was clearly mentioned that any offense that you report will have to be reported to the legal authorities. We also developed a cultural assessment tool so that we could see from which background the person is coming and then accordingly proceed with the therapy. Large-scale awareness activities were undertaken, webinars to educate and reduce stigma, and a social media campaign was undertaken. One other important step that we did was translating the trouble desire management tool into Indian languages. So it has already been translated into Hindi and Marathi, which is Marathi is the language that is spoken in Maharashtra, and Hindi is spoken by about 60% of the Indians, and 6 other languages are already being translated. So observations from the program were, it was difficult to obtain support from therapists, from the government, from the legal system. The enrollment rate in the program was low. The people who approached us also wanted a lot of times help for other psychosexual issues which were not related to pedophilia or hebephilia or even the risk of offending. The providers were many times mistreated as erotic service providers with lewd calls sometimes. Accessibility was an issue because we operated only within Pune and Mumbai. So two cities, two metro cities in the state of Maharashtra, whereas India is huge and a lot of people from all over India could not approach us. A lot of people expected immediate consultation. Dropouts were there after initial appreciation of the program. Clinician safety, we had no mechanism in place to ensure. So patients could be threatening sometimes, and we would have to fend for ourselves. However, there were also positives. There was no backlash from all the webinars that we took. However, it was a little difficult to create acceptance. So at face value, there was a lot of acceptance and appreciation, but in terms of enrollment or coming forward to take part in the program, that was low. Participant related observations were that there was a lot of dependence on cooperation from the participant. We had no role of we could not involve relatives or somebody else, because a lot of time the participant themselves were coming forward and saying that they had a pedophilic orientation. A lot of times they expected cure. They had difficulties in identifying their own sexual preference, stigma, hesitancy, fear of being reported. Many times it was ego dystonic attraction towards prepubescent children. They again had cost issues, difficulty in understanding the program, and reluctancy for psychotropic medicines. Let's come to treatment. I'm sorry if I'm rushing, but I'm just trying to make up for the time. The program is really huge, so let's hope we are going for a gist. Treatment consideration. So we know there is no cure for pedophilia. So what are we treating? We're treating the distress, we're treating the comorbidities, and we're treating the behavioral problems. So distress in terms of the orientation and creating some acceptance, some level of integration into the sexual self-concept. Comorbidities are very common in this section of the population, about 30 to 60% comorbidities. Behaviors, we are treating both the offense behaviors and as well as the viewing of the child sexual abuse material. Why are we doing this? Because we want to prevent both kinds of offenses. So even if there is no contact offense, viewing something online also involves production of material which is again harmful for children. And those who have pedophilia, they should be able to live distress-free life, because pedophilia is not something that they choose to have. It is something that is given. They are not responsible for that. So we are trying to take people with pedophilic disorder from pedophilic disorder to pedophilia. It's a simple orientation. So the project operates under the premise that you're not guilty because of your sexual desire, but you're responsible for your sexual behavior. So everybody can have their own orientations, desires, urges, but they are responsible for how they behave. And that is the most important part. Under the project, we had a treatment, we had an enrollment protocol, rather, I would say, and that involved a flowchart which ensured that the patients were given anonymity, confidentiality, and the entire treatment was free of cost for them. This was provided for self-identified, motivated to abstain, and non-offending persons with pedophilic disorder. We also had included people with hebephilic disorder in this. The treatments included psychological as well as biomedical treatment. Most important aspect was again patient compliance. There was nothing we could do if the patient did not want to come. Psychological treatments included relapse prevention, CBT, risk need responsivity approach, which is the Good Lies model, and mindfulness therapy. Biomedical, androgen deprivation therapy, that is ADT, psychotropics for the comorbidities, and some drugs which also as a side effect reduce the sexual desire. So SSRIs, lithium, amisulpride are some examples that were used. I will give it up for the questions and discussions. These are some of the points that I could think of. Are there similar programs that you have come across? And what are the different challenges and solutions in your cultural context? Do you think there is an importance for this program? Is it important? And what is the need in your, again, cultural context? What can be done to have similar programs in other countries? What modifications of laws, if any, are required? And what are the therapeutic interventions that we can offer to offenders? And should we? What is the opinion? Thank you so much for your patience. And I will give it to Dr. Vasudeo Paralikar.
Thank you. Thank you, Suchita. Thank you, Ankita. We come back to questions. And I thank the audience for staying on 1 or 2 minutes of technical glitches, but otherwise you have seen how vast the topic is and how we had to condense it as much as we could. Okay, so the first question is, could you please give examples of pre-marriage counseling, please? That is perhaps question for Ujjwal.
Yeah, example of pre-marriage counseling means sometimes the couples who are engaged and they come forward for seeking this pre-marriage counseling, and then we have to formulate or the sessions. Sometimes it will require one-to-one session in case of child sexual abuse, or maybe a girl wants to disclose, or maybe boy wants to disclose some of the things which are related to sexuality. But other than that, the marital roles and partnership, and basically nurturing the couple relationship. So we need to discuss all these issues in pre-marriage counseling. And nowadays what is happening, even divorcee persons are coming because they have collected some negative experiences from their prior marriage, and they come forward for seeking help in terms of pre-marriage counseling.
Great. Thank you, Ujjwal.
Yeah.
If a person faces sexual violence from a colleague, but not in the workplace, what can be done to safeguard the client? What steps should be taken?
I think it is in reference to POSH Act.
Yeah, it is.
I think the POSH Act can apply even if it doesn't happen in the workplace. You can go with that, but first we need to ensure that the violence is, stopped in some way, and safeguarding and empowering the person to take measures to be safe, which depends on case to case. Actually, we would need to know that details, but the POSH Act will still apply. It is very important. We learned from NGOs while working on this project that the person needs to know which act to apply when reporting. So if the act is not correctly written in the FIR or the complaint, most often the case doesn't go ahead very well. So sometimes this is where social workers, legal support from NGOs are very, very helpful, because they are more acquainted to know which act does it come under. So maybe having access to NGOs is very important, and not to directly rush into, that's where the structural competence comes in, having structural elements in place, having, the context in place of the workplace also. If this person is the only provider, in many times in India, I've seen in my clientele that if you report systematically, you are made to resign in some way or the other by harassment. So if the person is the only provider, we need to consider that as well. So there are multitudes of contextual factors that, again, this assessment will help you understand, and then prioritize what steps can be taken to ensure that first step of safety and further interventions.
Yeah. Just to add that, if your institute has an internal committee, sexual harassment committee, then in that case, even if the colleague is harassing a person outside of the workplace, still there is a provision of that person can go and report his behavior to internal committee of sexual harassment.
Thank you, Ankita and Ujjwal. The next question is toll-free helpline. Can we have that? We already have it, troubled-desire.com. And it is, yeah.
They want the number.
Yeah.
Hello, I'm Varsha here.
Yeah.
I'm typing it for everyone, so everybody
Great.
can find the answer in the chat box.
Okay. Thanks, Varsha. The next question is, when it is extremely difficult to identify potential offenders, how do you run a preventive program against pedophilia?
Can I take that?
Sure.
Thank you. So what we did was we created a lot of awareness regarding what pedophilia is, and if they were able to identify. So it's relatively easy, just like an orientation, so just like a person knows they're attracted to males or females, similarly, they know that they are attracted to a child. So if they can identify it in themselves and they would like to seek help, they are fearful that they might offend, they might do something, or it's causing some distress, difficulty in their interpersonal relationship. We had some of them who were married, so it caused difficulty in their marital life as well. So they were invited to approach us through this toll-free helpline. And once they reported that this is something that they seek help for, then a consultation was set up with one of the consultants, and the process was started after due consenting and everything. I hope that answers your question.
I hope you have got your answer. The comorbidity is important. The sources of referral are important. The degree of trust that the client has among the all these elements of the care provider system is very important. Coming to the next question, it's a bit tricky. If an adult, 21-year-old, reports abuse from a relative that went on for 8 years until 1 month before first consultation, does mandatory reporting apply? Suchita has done a lot of homework on this, so I would happily hand it over to Suchita.
Thank you. So the law is not clear about when an adult approaches us, but for all contexts and purposes, yes, it does apply. So to safeguard ourselves, yes, we have to mandatorily report. Of course, mandatory reporting does not mean that you go behind the back of the client and, without informing them, you're doing this. You discuss this with the client. You say, this is what I have to do. And that is when you decide that the client is on the same page as you and what could be the pros and cons of doing that. Of course, you again reassure them that it will not hinder their therapy. The therapeutic process will go on. I would definitely like to hear from Dr. Ujjwal as well.
Yeah, so I think if that offense has started after 2012 when the POCSO was launched, and this was going on for 8 years, so I think they should complain. They can complain under POCSO. Right now, the person is 21-year-old, but it must have started when he was child. I mean, child below 18. Okay, so they can go ahead with legal processes.
Even without POCSO, you can complain.
Yeah, of course.
That is in IPC as well as
Yes.
images and different acts. And there is no problem about that. Yeah.
Can I just add one thing, that what is the purpose of POCSO? It is that these cases are fast tracked. So a lot of cases in India, court cases are pending. So the whole purpose of POCSO is these cases are given priority, and there is a more stringent punishment that is given so that people are deterred from sexually abusing children.
One genuine issue around this is what happens if the clinician complains even when the victim and the family are denying, are refusing to complain, and that leads the patient to the victim to attempt self-harm. then who will take the responsibility? So more rather than just technical rules, more authority has to be given to the clinicians. You may consider them as amicus curiae or friend of the justice, or the quasi-judicial power should be with the counselors, like they are in some other countries, where the counselor has a discretion when to report, whether to report. But that is a debatable issue, and when we'll have to do something to change the law, then perhaps that will come into picture. I hope it answers your question. I'm concerned in finishing in time beforehand. If the organizers and everybody allow us some more time, we will have more discussion about it. Just a moment. Yeah, is that Medha?
One question.
Yeah, Medha.
Yeah.
As a clinician, how do you deal with your own morality, ethics, acceptance of diverse natures of sexuality? Do clinicians go through any special training in being non-judgmental?
I think you have to do a lot of work with your own self before you start working with such delicate issues, and you should not be vulnerable for having internal moral conflict and emotional pressure. So you need to work with your own self.
I might like to add a couple of points here. If you have doubts, then you should join our program. You will definitely increase your capacity of non-judgmentality and destigmatization. And there are stories in every religion. Jesus' story about what he did to a lady who was accused of adultery. Every religion, there are stories that might be appealing to that particular patient. And if generally we come to the health acceptance of the patients by say, which are not conflicting the morality and the ethics or the legal aspects, then perhaps we are on a good stead. For example, if a person believes that I will not judge the other person, from my end, I will not make any transgression, then that should be sufficient. It will help the clinician to have excellent rapport with the patient, which is authentic and accepting. That is my personal experience in dealing with these extremely stigmatized situations. I hope it is okay. Otherwise, we'll get back to it. We thank all the questions. They're absolutely important, and I'm sure they will help us in our program further. The next is compliment. Very informative webinar. Thank you so much. Thank you, madam. Then why do people
Who are not pedophiles sexually abuse children?
Yeah.
There can be multiple conditions, like a person is having some comorbidities, under some hallucinations, some psychiatric illnesses, or maybe a person is having some ASD symptoms, or with personality disorders, or maybe a person is having intellectual disability. In such cases, and sometimes people are not able to have established relationship with adult partner when it comes to sexual intercourse, and also that case also they can try on children. And even Suchita can add on this, and even Vasudev.
So I would just add that in addition to this question, there is also one more question that troubles us, is that why do some pedophiles offend whereas others don't? A lot of them are just living their lives without ever offending, without ever coming to light, and they're just going on living their normal lives. There is something that Sir always says, that is Bal Brahmachari. There is a concept. Sir, would you like
many of them would be wise and discreet enough to have not disclosed it to anybody, but staying off the mainstream, realizing their vulnerability. That is quite possible. But coming to surrogate offenses, there can be vicious intents and motives, where actually long-term psychotherapy should be required, where revenge and objectification and such negative character traits are particularly involved. So it is a very difficult topic, and as I said, this is a multidisciplinary area. Everybody is a stakeholder. We need forensic psychiatrists, we need legal officials, the judiciary, the prisons, everybody. Okay, Pablo has to leave in a minute. So I thank Pablo, thank you again for being there, and request Mario to please be there with us until we take some 5-10 minutes more or more if you can. Is that okay?
Yeah, thank you very much. Great presentations and wonderful to have this activity for WACP. It's so important to be able to engage in sharing the learning of such an important program, Vasudeo and colleagues. So thank you very much.
Thank you. Then our friend comments from UK, Dr. Rajesh Nehete. Congratulations to all. Extremely difficult topic. I may have missed this, but what was the operational definition of a pedophile? Was it related to age of the victim?
Okay.
Suchita.
So age of the victim is not considered while defining a pedophile. It is the Tanner stages that are considered. So we say pre-pubescent, that is before any sexual development, pubertal sexual development begins. So Tanner stage 1 is what is considered attraction towards that stage. Of course, there is a whole part where it has to be persistent and recurrent and lasting for 6 months according to DSM-5, and some distress is associated.
Thanks, Rajesh, for this question. And still, patients can cheat all kinds of tests. It may be viewing time, it may be penile plethysmography. There are umpteen stories which Ujjwal and myself and Katharina, when she was here, and all our team have gone through over and over again. And yes, we agree there are limitations, but if the person is self-identified, motivated, and non-offending, with whom we have experience, they are extremely grateful for what we do, and that is our reward. With all the risks that we take and our team takes, and risk to researchers, as was the article in Lancet in since 2006, we should have certain measures in place. Okay, let me hurry to the next question. Has your team or anybody else in India conducted a broader survey or a research study to know the spectrum of sexual behavior in Indians? Who would like to take that?
Hello, sir. I would like to take this.
Great.
Yeah. So good evening, good morning, good afternoon, everyone. My name is Varsha, and Dr. Paralikar has already introduced me. So I would quickly like to answer this question. Our team had conducted prevalence study on paraphilias among adult population of male, and we collected a sample of 300 adult male population, which was conducted online and offline, and the analysis is in still process. So we will be soon coming up with our results and findings. So this would be I think one of the first kind of a study which is done in Indian population about studying prevalence of paraphilias in adult male population. So thank you.
Thanks, Varsha. There are other, a couple of papers, I suppose, from PHFI from Delhi and from some southern states, where they commented that pedophilia was also seen among women. The paper from Mysore, I suppose, Tamil Nadu, and which are the paraphilias which are common in women than in men. So that is there, but they are still, there are several limitations. They are based on self-report. There is no concrete distinction. So let us hope. We are creating the ground. We are taking baby steps, I agree, but they are definitely in the right direction. And the work needs to go on in this direction so that people speak more freely. It is unpacked, disambiguated, and destigmatized, and then care would be more possible. Okay, Dr. Sudipta, we thank you for your compliments. Then
if the abuse occurred in minor age, can we lodge a complaint under POCSO Act in major age?
Yeah, that
Yes,
was a
yes.
question which Suchita mentioned, and Ujjwal also commented on it.
Yes.
If the offense had occurred before 2012, then perhaps you may not be able to apply POXO, but still there will be other laws. And if it has happened after POXO came into picture, if the person is now major, then whether it is his discretion or is it still mandatory reporting, we do not know. And that needs to be, there is no case law, as you will see. This is just a bare act of POXO yet that is working, that is operational. And because there is no case law which will build over time, then perhaps there will be changes. So we appreciate this question. There are nuances, many finer nuances. Are there special legal provisions to protect intellectually disabled adults who faces is coerced into sexually inappropriate act online and video is shared online as a blackmail? Ujjwal, perhaps this is appropriate for your experience.
Not really. I have not come across a case like where these kind of issues were dealt. Suchita, can you?
Yes, so the Indian Penal Code, that is the IPC and the CRPC, Criminal Code, they have a section. So just under the section where rape is there, there is an aggravated section which includes intellectually disabled, and even there we already had a provision for those under 12 years of age. So for children, intellectually disabled, and such kind of people,
Or persons in responsible positions.
yes, and also yes, persons in place of authority also. So any assault done by those people is also considered an aggravated assault, and there is more stringent punishment, but it all comes under IPC and CRPC. There is nothing in POXO for intellectually disabled separately.
Yeah. And the last question.
But they are considered as a children only. So
yes, because they
yeah, because if a girl is on 25 years old, but mentally she is some 5 or 7 years old, then definitely it goes under, I think it undergoes that POXO. Yeah.
This question from Srushti is not really very clear to me. My team can help me. Are there any gender differences in the level of offense perpetrated in pedophilic patients? I would like to add, really respect the work that you are, that is fine. Compliments are fine. Gender differences in the level of offenses perpetrated.
German data?
Yeah. So again, gender differences we don't know. Majority of people who have approached are males. We don't have data on females at all, so that we cannot comment on this right now.
And another point I would like to add is pedophilic patients are not the same as child sex abusers. Not all pedophiles are abusers. So we'll have to find out how many among the pedophiles were offenders and then take your question.
And since we have only dealt with non-offending pedophiles, it is again difficult for us to comment anything about an offense that has occurred.
And we were lucky to have those who had excellent rapport with us, apart from barring a few who dropped out. So that we are very much thankful to them. The next is, if the client and family are against the approach to report CSA, is the therapist still responsible for reporting?
Yes.
Yes, we are unanimous.
Yes.
There are instances where the counselor was silenced into not reporting, and later on things came out after months or a year, and the counselor had to face the legal action.
Because the it's obligated by law to report for the clinician or anybody, not just clinician, who comes to know about child sexual abuse. Otherwise, the person who knows and did not report is liable for punishment of some money or 6 months of jail as well, depending on, I think, the case to case. But therefore, we need to know how to make these people, the families, understand the importance of reporting, and we need to be working in close knit with NGOs. NGOs are doing very good work all over India in understanding and approaching people and making it a little more easier to approach the authorities as well.
We thank you all for your compliments, and we are just doing our best, and we need your blessings as well as support. So we are thankful, Samir and Babu Sahib, and all the earlier compliments. Thank you so much. I would request Dr. Mario to say a couple of words.
Thank you, Vasudeo. I think I speak on behalf of all of us that this was a very interesting view of how you look at this complex issue in India and how you treat it and how you try to prevent it. And of course, as always, a lot of questions remain. And thanks to that, I guess we'll meet each other again in the near future for another discussion and other progress, and also exchange of ideas, like is hormonal castration something that is useful in treating pedosexuality, or what to do about the laws to protect women. You all know that India is one of 40 countries in which when you rape your wife, you cannot be punished. And the same is in China, in Iran or Iraq. And those are laws that are very difficult to understand. And it's very difficult to understand why they are not changed and to protect women. And there is just a few examples of a lot of work that remains to be done. And we as humble doctors and psychologists, we can only treat people who suffered from that or try to prevent it from happening. And I think this session made a huge contribution to increase that power that we have to help people. And I thank all the three presenters and Vasudeo, you as well, for sharing this with us. And it's great that within the WACP, we have such active groups like yours, and we hope to hear again from you in the near future.
Thank you so much. And just one point, I saw Director ma'am was there. Just if she wants to speak something to you, Dr. Laila Garda is the director of our KM Hospital Research Center, who supported this program. Otherwise, everybody was not keen to take this up. And
great.
Yeah, so she's here to speak. If she wants to speak something to you or to the audience, ma'am, you are welcome. You are muted, ma'am.
Sorry. Good evening. Yeah. I want to actually thank WACP for giving our institute this opportunity to present our work, which we have been doing. It has been a very challenging task for us, and we also took it up with a lot of hesitation, but we have progressed. And as Dr. Paralikar said, these are small steps which we have taken, and we have moved ahead, and we hope to continue to take this forward. And I think this platform, the WACP platform, served as an excellent place for us to showcase what we have done and share the work nationally and internationally. And I'm very grateful on behalf of the Institute that we were given this opportunity. And I really like to thank the entire team who have worked very, very hard through this program and for this presentation. And I hope that we can take this on a long-term basis, where we could have more such interactions and seminars to spread this message on a larger scale. Thank you so much, Mario.
Thank you, madam. Culture and sexuality being linked so much, we must expect that we are having a long-term liaison with WACP and our programs regarding sexuality, prevention of sexual violence. I thank again all the audience, my teachers, my colleagues who have come on a Friday evening in India, and they have been there on their working day. So I thank you all and hope you continue to give us the same kind of support in future. Very kind of you. Thank you, sir.
Thank you.
Thank
Thank you. Bye.
Thank you.
Bye-bye. Thank you.
Bye.
Thanks.
Thank you. Thank you.
Bye-bye.
Bye.
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 Thank you. Thank you.
Is it okay to leave?